morning we're going to go over the Peacock Press. We're going to go over some metatarsalgia treatments with minimally invasive surgery. And also we're going to show you how to perform the Peacock Press, how we use the ultrasound with it, and also how some of our traditional ways of looking at metatarsalgia will not help sometimes, or not be as complete of a picture of what you need before you perform surgery. I want to show you first a concept of foot typing. If you look at this patient's foot, now this is 9 months after we've done the surgery, but I'm going to show you her foot. If you get her in root neutral casting position, loading both the 4th and the 5th metatarsal, and first we're going to test the rear foot. You can see her rear foot. If you imagine a vertical line here, her rear foot will not go past the vertical axis. So she has what we call, if you try to evert or invert, when you evert, it will not go to the vertical axis. Neither will her inversion here, or the inversion of her heel. So she has a rigid rear foot. Now the next thing we do, remaining in the subtalar joint neutral cast position described by Root, we look at the first ray as it relates to the 5th ray with the 4th and 5th toes loaded. If you push up on her first ray here, you can see that that first bone here goes above the 5th metatarsal. So that would be supinating the forefoot. When you look at the pronatory end range of motion, you can see that it gets to about the level with the 5th ray, with a little bit further pronation than she has at neutral here. So basically what she has here is a first ray that goes way above the 5th ray and slightly below the 5th ray with the pronatory end range of motion. So this patient has a rigid rear foot and a flexible forefoot. And this is very important before you do metatarsal work to know to realize what type of foot you're dealing with. Now when she came to us 9 months ago, she had an extremely severe IPK under the 3rd metatarsal. What we did with her, we performed metatarsal osteotomies in a minimally invasive fashion, percutaneously, on the 2nd, 3rd, and 4th. Now the way we do these osteotomies, we will place our 2nd osteotomy just slightly proximal, the 3rd slightly distal, and then the 4th slightly proximal. The reason we're doing that is you don't want any bony bridging to occur between these metatarsal osteotomies. Now she is actually back to work and completely pain-free with no pain in her foot at all. Now the other thing is the concept of equinus. Not all of these patients have equinus. If you look at her foot here from the side over here, we'll test that for you. So we're going to have her extend her knee totally straight, supinate her foot slightly, pull her foot up. You can see she has great range of motion with dorsiflexion of her ankle. So she does not have equinus. And with the knee bent, you got the same kind of basic move, even a little bit better. So in this patient, doing the gastric equinus would not be the most favorable surgery for her. So we're looking at bony work to get rid of her pain. Now with these osteotomies, after you do these, there is some pain in the top of the foot for 2 to 3 months. Now, I developed a test for these types of patients called the Peacock Press, and we're going to show that to you real quick. What the Peacock Press is a very simple procedure. What you do is, once again, get into root neutral position, subtalar joint casting position, and in this position, for this patient, you press up on the hallux, 2nd, 3rd, and 4th metatarsals, and when in a pathological foot, you'll see blanching, which occurs under the metatarsal where you're having the most pressure at toe off. So, and you can see she's got a pretty good, nice parabola here. There's nothing really, blanching really quick. So this is after the surgery. So this is really good. Now before the surgery, we did the same thing on her, and you could see a lot of blanching in the 2nd and the 3rd metatarsal, as well as some in the 4th. Now, traditionally we go by X-rays to decide what metatarsals to perform surgical correction on, and that will not really tell you the whole story for a patient's foot. That doesn't tell you whether the patient has equinus. It doesn't tell you what the metatarsals look like at toe off. and it certainly doesn't give you any indication of the vertical depth of any of your metatarsals. Now, what we traditionally have done is the axial sesamoid, and this is her axial sesamoid here. Well, like I said, her pain was under the third metatarsal. So if you were to look at this axial sesamoid and go only by that, you would think that we would be okay by just doing the third, maybe the fourth, to get a real even metatarsal parabola. However, interestingly, this is not how this foot looks at toe off. So one of the things we can do with the Peacock Press that you can't really do with these x-rays is to look at what the metatarsal look like at toe off. So to do that, we do our test preoperatively just like we did before. Subtalar joint root neutral position, push back on the toes on how it would look at toe off. And what we can do, we can take our ultrasound at this point and actually examine our metatarsals like this and actually get a view of the metatarsals. And here's the view of that. So now here we are. We're at 9 months post-op metatarsal osteotomy, second, third, and fourth. And we came to the conclusion of needing to do these particular metatarsals by using the Peacock Press. Now she's 9 months out. Her pain is completely resolved. So we're going to show you the testimony as well in just a few moments. What we're going to do today is look at this now 9 months later, utilizing our ultrasound and the Peacock Press as well. So we're going to do that right now. Okay, so once again, it's a fairly simple test. We get the patient's foot in root neutral position, and basically, and this is subtalar joint casting position, and we basically press back on our hallux, second and third toes here to examine any kind of blanching we get in the metatarsals. But we can also quantize this with an ultrasound image as well by just taking our ultrasound probe and examining the metatarsals in this position. So that's what we do with this. We take this and basically place this under our metatarsals, and we can see our view of this now. So we're going to look at that. We'll get a real good view here. So in our position now, we can now see our metatarsal heads here and what position they're in. This is 9 months later. The way we've held the probe is we're looking at from medial being our second met to the fourth being the lateral being our fourth metatarsal. From this position, we can obviously now measure. So we come here and hit set on our little ultrasound here. And basically we're going to measure the depth we have here from, this is our skin line here. So that shows out to be 0.81. So we hit this and we're going to measure, this is our third metatarsal, measuring up to the skin line as well, once again. That's 0.77. So you see they're fairly even here. Now let's look at the fourth metatarsal. Hit it. It's a good measurement here. This is our skin line here. And that's 0.69. So really what you're looking at is a fairly, these are pretty close measurements, 0.81, 0.7. 0.69. So really fairly the depth of these metatarsals at toe off are pretty consistent compared to preoperative views here. We can look in our third mag and see we still got a little bit of inflammation here, so there's still some secondary bone healing occurring here, and that's what you're seeing there. That's not really inflammation or pain with our foot. So if you were to compare this, what we have now, with what it looked like in pre-op, this is our ultrasound image at pre-op. And so you can see at pre-op our measurements are certainly different than they are now today, 9 months later. So this has been a successful procedure, much of it due to the fact that we were able to use the Peacock Press to evaluate which metatarsals we needed to do osteotomies on. So now at this point we're going to kind of do our testimonial, and that's the end of the academic part. So just wanted to show you how we do the Peacock Press and why it's done. There's one thing you have to do a little bit different in certain patients. In some patients, you're going to find that the first ray is extremely hypermobile. So in these patients with an extremely hypermobile first ray or an extreme supinatory in-range motion, the test is done slightly different. For these patients, you're going to have to make sure you put a lot of pressure on the hallux as well. For our patients that have a stable forefoot, you can actually plantar flex the first met, because in a stable forefoot patient, you would assume that the peroneus longus muscle is contracting properly and plantar flexing the first met down. I guess it's a little bit more complicated biomechanics, but it's fairly simple once you learn the concepts of functional foot typing and what we mean by a rigid rear foot as opposed to a flexible forefoot, or a flexible rear foot and flexible forefoot. This has been described by Dennis Chavis, and it's a great way to kind of evaluate people really quick before surgical corrections. Okay, this is our testimonial portion of the video, and I personally think testimonials are very important because academics are great and everything, but really what we're trying to do is help patients. And if a patient tells you that these procedures work, in my opinion, it means more than what I'm telling you, because that's what we're really trying to do, is to help patients and get them pain-free. And all of these tests and all, they mean nothing if they don't really benefit the patients. So it's just academic other than that. So we're trying to make this more of a real-world type of examination and test so that the patients do well. So that's the purpose of this. So I think testimonials are extremely important. So here's our patient. I'm going to show you her foot once again. She came to us 9 months ago with extreme pain in her foot. Tried all kinds of conservative things. Nothing really helped. She had a really bad IPK on the third metatarsal and just quite a bit of pain, and was actually having, she's on her foot a lot at work. She's having a lot of problems. Now this is 9 months later. You can see that the IPK has basically resolved. If you look at the dorsal aspect of the foot, you can see our small little incisions here where we did the percutaneous metatarsal osteotomies through minimally invasive surgery. We did not fixate these osteotomies, we let them find their own level, sort of like they did back in the old days. And this is sort of bringing back the old to the new by doing slightly different techniques in a new way, but some of the concepts that were talked about years ago. Now, we didn't do gastric equinus surgery on her because she didn't have gastric equinus. Now, we're going to kind of talk to our patient. Here's our patient, and we've known her probably a little more than a year now. And I'm going to ask you something before, just in your own words, before you had the surgery and we corrected your foot, how much pain were you having in your foot? Would you call it from 0 to 10?
10.
So was it hurting a lot?
Mm-hmm.
And your normal daily activity, say at work, was it slow? How bad was that affecting your work?
It was affecting it bad. I couldn't hardly stand up. My foot was swelling.
Yeah.
Every chance I got, I had to sit down.
Right, so it became a very aggravating, painful deformity for you. And ironically, metatarsalgia, which is what you had, that's one of the most common foot pains, and sometimes not addressed properly. So you can get treatments that don't really work for it. We tried all the conservative things for it, didn't help. Now, after the surgery, obviously it was kind of painful. So describe your pain after the surgery, and most people have it more on the top. Is that how you experienced it?
Yeah, mine was on the top.
Right, so in these particular surgeries, you can expect a 2 to 3 month dorsal pain. The plantar plane kind of goes away quick, and then dorsal pain will begin. And that's just a secondary bone healing. So this is not a quick, you can't do this surgery and go right back to work or go back to normal activity. You have to have time for your foot to heal properly for this. Now, the way we did her, we had her in a cam walker for approximately 3 to 4 weeks, and then we got her in a surgical shoe. Now, Tammy, at this point, we're 9 months out. What's your pain levels now? How are you able to do things now?
0, back to normal.
Back to normal. So at work now, when you're at work, and obviously you're a busy place where you work, are you having to stop now to rest your foot? So there's no resting your foot. How about the personal stuff you do? Does it slow you down for that?
No, I'm back to normal.
Do you think about your foot at all anymore much?
No.
That's it. Well, see, that's to me that's a great testimonial. The simple question: do you think about your foot anymore? And if you say no, then that means it works, because we don't really in our day-to-day lives don't think a lot about our foot. It's a very important structure, probably one of the most important in your body. Your whole body's important, of course, but your foot's very important. But it's not something you want to go around thinking about. You don't want to think about, my foot hurts today. Well, how am I going to arrange my schedule today to accommodate my foot today? So this patient, utilizing the minimally invasive surgeries that I learned from the Academy for Foot and Ankle Surgery, and directly from Dr. Stephen Isham, and some of the techniques he has described. They're also available in DePrato's book. I'm able to treat patients, get rid of their metatarsalgia. Not for years I got where I kind of would walk away from metatarsalgia, thinking maybe it's best not to treat it, because the treatments are not really effective. But with a combination of looking at the foot type, treating the patient with metatarsal osteotomies, gastroc resections if need be, we can get these patients back to like normal life in a type of deformity that can be kind of a headache. If you do some of this stuff the traditional way, you get transfer pain. So if we were to just perform her third metatarsal, it's most likely in her foot type, she would have had pain on the second or the third metatarsal. So there's nothing more of a headache than to try to deal with now you fix one pain, and now the pain's traveled somewhere else in the foot, so you're back to square one. So the purpose of these videos is to show that multiple metatarsal osteotomies are important to do in certain patients, and we have tests now to show you why that's important. Because when the patient has metatarsalgia, what you're having to consider is how the foot looks like, what it looks like at toe off. And the other important thing about the Peacock Press, which I really love about this test, is it's both subjective and objective. So it's equally both. And you can do it while you're doing the surgery, which I have a view of her right after the surgery, where it shows the level of the metatarsals. It's easy to grab this, have a sterile head here, and perform this during the operation, whether you've done this traditionally or with the MIS. And you can do this before the surgery. So it's a test you can do preoperatively, intraoperatively, and postoperatively. We have a lot of tests that are great, like plantar plate pressures, but you can't use that during the surgery. Even x-rays are hard to get during surgery. So with the Peacock Press, you've got a quick little test that will really tell you a lot of information about where these metatarsals are in the foot at toe off and how you need to address that. I appreciate you listening to the video. I think this is a very important concept, not for getting the word out about the test, but just because this helps patients and it gets them back to pain-free life and not thinking about their foot anymore.